Good morning, everybody. Welcome to another session of the Clinical Epi teaching rounds on Saturdays. The last few weeks we heard some excellent sessions from Namrata Mathew. Today Namrata is going to take us through target trial emulation. She'll explain what is a target trial and critical appraisal of an article which has used target trial. So over to Namrata.
Thank you, sir. Good morning. I'm Namrata. Today I'll be taking a talk on target trials and target trial emulations. So let's dive into the topic. So the structure of today's talk is we are actually looking at what is a target trial and why must it be emulated, what is the target statement, and we are looking at appraisal of a clinical trial. First to understand what a target trial is, we have to understand what is causal inference. Maybe people from statistics will be more familiar with this, that correlation is not equal to causation. When we need to find out whether a particular exposure is directly causing an outcome, we need to design a trial that is made specifically to understand causal inferences. So, for example, if you have a chemistry experiment and you run the same experiment at two different temperatures and you get the outcome in experiment A and you don't get the outcome in experiment B, then we can directly say that the difference in temperature was the cause for the difference in outcome. So this is an example of a closed system where all the variables are controlled by one person and you're varying only one thing, which is the causal factor. But in real life, in patients and in diseases, they are open systems. There are many things which might affect the exposure and the outcome, like a confounder which we are not aware of and we might not be able to control. These are open systems. So there comes the example, the importance of understanding what a confounder is. A confounder is something that independently affects an intervention and an outcome. For people who are not so familiar with the lingo, for example, if I exercise and I have less cardiovascular disease, we don't know whether it is because I exercise that I have less cardiovascular disease, or whether because I also eat healthy, I have less cardiovascular disease. Simply because people who exercise are more likely to be eating a healthy diet. So healthy diet independently affects my ability to exercise and independently affects the outcome of developing less cardiovascular disease. So this is the principle of a confounder. Now, the most important thing why we say that randomized control trials are the gold standard for understanding causation is because it can eliminate all known and unknown confounders by randomization. So, causal inference relies on these four inference assumptions: exchangeability, positivity, consistency, and no interference. I am just explaining these in simple English terms. There are actually detailed mathematical theorems behind each of these. So, exchangeability means the intervention arm and the placebo arm, the control arm, are so similar that you can flip them. And you can do the intervention on the placebo arm and the placebo on the original intervention arm, and you will still get the same result. If you have randomized correctly, you will have exchangeability between the two arms of a randomized control trial. Positivity means every person in your study has at least a mathematical chance of receiving the treatment or the intervention. For example, if there is a pregnant woman with sepsis, I cannot not treat. I cannot choose not to give antibiotics. Similarly, if somebody is allergic to a drug, I cannot give them the drug at all. They have zero chance of getting the drug. So when the important thing to note here is when you have an RCT, both people are equally likely to get either treatment. Now consistency is, this is just a cartoon to demonstrate that. Basically the idea is you should define what your intervention is clearly. Does high cholesterol cause heart attack is not the question. Does a cholesterol lowering drug reduce the risk of a heart attack? And more correctly you should say, does 10 mg atorvastatin taken every day at night reduce the risk of a heart attack? So consistency means you should be able to clearly define your intervention. And no interference means what one person is experiencing has no effect on the outcome that another person will experience. For example, if I am doing a vaccine trial for corona and I give person A COVID-19 vaccine and then his roommates are person B and C, Person B and C has less chance of getting COVID after that. So that is interference. But for a blood pressure lowering drug, if person A's blood pressure is lower, doesn't mean that if I give a blood pressure lowering drug to person B, then his blood pressure will also be lowered. So these are the principles of causal inference. So all of these automatically by the design of a randomized trial are taken care of. So much so that JAMA has actually said that causal language like effect and efficacy should only be used for randomized clinical trials. For all other study designs, including meta-analysis of randomized clinical trials, methods and results should be described in terms of association and correlation and not according to cause and effect wording. This is according to the AMA Manual of Style edition 11.2. But what is this targeted trial emulation? So, but in real life, RCTs are not always feasible or ethical. RCTs are costly, they are long, sometimes for long follow-up diseases they are prohibitively difficult. When it is not possible to carry out a randomized trial, observational data can be used to answer similar questions. However, observational data is plagued by structural biases that undermine their validity, which I will come to. So target trial emulations are basically a way to design observational data to help make causal inferences from it, to eliminate some of the systemic flaws. It doesn't eliminate everything, we will come to it, but it eliminates some systemic flaws in observational design. It is a framework to help you design observational studies as such. So this is what I said before, that it is a structured methodological framework for using observational data to estimate causal effects of healthcare interventions by mirroring a hypothetical randomized control trial, which is called the target trial. So what you first do is you think, if I had to design an RCT, how would I design it? How would I design it? That is your target trial. It is a hypothetical RCT. After you decide this, you can either design an actual RCT, and I was just looking up for, in India, the costs per patient to run an average RCT for about a year is $3,000 to $5,000. This is about 60% cheaper than US or Europe. So imagine if we had 100 patients, how much we would spend on running an RCT. Or if you could not do this, you can design a non-experimental analog, which is called a target trial emulation. This is an observational study that is designed to remove some systemic biases and made to look like the RCT that you initially thought of. So why do we need to emulate this target trial? There are inherent biases in observational studies like confounding, measurement error, attrition. And there are some errors that occur due to the trial design like selection, immortal time, misclassification. I just wanted to give a few examples of selection bias and immortal time bias, which are two important biases that occur in observational studies. This is an excellent paper by Hearn and M.A. et al. Written in 2016. They have a detailed explanation. This figure is taken from that paper. So let me just give you an example. So suppose, so time 0 is the time from which you are starting follow-up. Okay? E is exposure and A is assignment. Now example, you want to follow up people who have colon cancer and you're giving them aspirin and seeing whether their outcomes are better in terms of disease clearance. Okay? So here your time 0 would be whatever time point you decide to follow up for. Your exposure will be a person who has colon cancer, and your A or your assignment intervention, that is, will be people who have aspirin. Now imagine if you start following them up after they have gotten colon cancer and been taken aspirin. Okay? So please note that all this is people who have already, all this has happened to them. So you are looking back in time, right? So you are taking data from a registry and you are looking at people who have had colon cancer who have also had aspirin. If you start following them late, after they have developed colon cancer and aspirin, you will lose this much of the outcome that happened to them, right? If some outcome happened to them 1 year before you started follow-up, you might miss them. This is called left truncation, which means you have started your time 0 or your time of follow-up too late. This is one kind of bias. Now the next one. Your exposure aligns with time 0. Your exposure aligns with time 0. but you have started your medication earlier. Okay, so what will happen here? I am people who are diagnosed in medical oncology OPD with colon cancer, that day itself I will recruit them, and that day itself I follow them up. But they might have started aspirin earlier. What will happen here? Somebody who died because of bleeding in aspirin, you might miss, because you are seeing the alive person who came to medical oncology, correct? So you will lose, you will select people falsely. Did everyone get this example? If someone has already taken aspirin and they have bled in between this time that I have lost following them up for and died, only the people who are survived with colon cancer on aspirin are being selected into your study. This is called selection bias. Okay? Now the last bias is immortal time bias. Immortal time bias occurs when your assignment or your intervention occurs after you start following up. Now, I can say that my criteria for choosing a person who is taking aspirin is they should have bought at least 3 prescriptions of aspirin. If they have bought 3 prescriptions of aspirin from pharmacy, then that means they are taking aspirin. This can be my condition in the study. Now, one person can fill in the 3rd prescription of aspirin 1 year after you gave the first prescription, correct? So, after 1 year from when I am following up, only, sorry, where is this point? 1 year after I started following up only, he becomes assigned to the aspirin arm, correct? Now, what will happen here? In this time, I might have lost people who are taking aspirin. Basically, this means that if I assigned him to aspirin at this point, then I am taking people only who came to this point of being on aspirin. In the sense, no event could have occurred to them in this time. The people who have, suppose somebody filled in 2 prescriptions of aspirin and died on the way, they will never be part of the assignment arm. Only people who are alive and were alive to fill in the 3rd prescription of aspirin will be selected into my study. This is called immortal time. Immortal time means your outcome of interest cannot occur to the people for a particular time, in the people in the assignment arm in the particular time. So what will happen here is, I will select lot of healthy people who have lived to fill in 3 prescriptions of aspirin. And I will lose people by definition of those who have not filled in that aspirin, the 3rd prescription of aspirin. So immortal time bias basically occurs when your time 0 occurs before your assignment. Now in an RCT, these 3 always coincide, because the time at which you randomize, you start follow up, you assign them also into a treatment arm, and you follow them up for whether they are eligible or not. Like first you decide whether they are eligible or not, randomize and assign them into the treatment arm and start follow up at the same point. So in a randomized control trial, time 0, A and E all occur at the same point. But in observational studies, it is not like that. Eligibility, assignment and time 0 might not be at the same time. This is why you have these problems of left truncation, selection bias and immortal time bias. Now, this is just a representative figure. This is from a patient in, this is from a paper from BMJ in 2026. See, this is what actually people do, investigators do when you have a person. When you have a person, you just have the entire history of the person. When were they diagnosed? When did they get this treatment? When did they get the next treatment? Right? So what investigators do is, for every patient, they make this kind of table. Then you decide, this is the time. You decide, is it hours, months, days, years? Okay, so if it's an ICU trial and intubation, then outcomes will change by the hour. So this is 0th hour, 1st hour, 2nd hour, 3rd hour. If it is colon cancer, outcomes might change only by the month. So this is month 0, month 1, month 2, month 3. Then at month 0, you decide, did they fit your definition of eligibility? Did they fit your diagnosis? Again, you reevaluate them. At month 2, did they fit your definition of diagnosis? At month 3, did they fit your definition of diagnosis? Similarly, at month 1, did they take at least 1 month of aspirin? At month 2, did they take at least 1 month of aspirin? At month 3, did they take at least 1 month of aspirin? Correct? So you fill in all this. After you have these tables for everybody, you decide your time 0 for each patient. As much as possible, when you choose your time 0, you should remember that you should try to coincide it as much as possible with your eligibility and your intervention. So target trial emulations actually do not eliminate biases related to data, like confounding, data measurement biases, etc. But they do eliminate biases related to the study design of observational designs, like selection bias and immortal time bias. This is one important concept to understand. This is why a target trial emulation will never be equal to a gold standard RCT, but it can be very close to a pragmatically done RCT. Now, when they were deciding how to make this target trial emulation protocol, they went through a long process and they actually made a protocol called the target protocol. So the protocol largely is like this. Step 1 is basically what I talked about, the target trial. You hypothesize what an ideal RCT would have looked like in this scenario. And step 2 is you actually emulate that RCT. Emulate means you try to copy it. You see how you can map your observational data into the data of this, into the structure of this RCT. Now, some terms that we commonly use in target trial emulations are causal question of interest, that is self-explanatory, it is just the question that you are asking. Causal contrast is different strategies that can be used to arrive at a particular result, like did you do ITT or did you do proper protocol. Causal estimand is an effect that would be estimated to answer your question. Can be any effect, like is it relative risk that you are estimating, is it mortality that you are estimating, and confounding is again self-explanatory. So why do we need a separate checklist to evaluate target trial emulations? That's because Strobe and Record, the current checklist that we use for observational studies, lack some key nuances that capture an emulation of a target trial. So a new checklist was required. So target stands for transparent reporting of observational studies emulating a target trial. So the target guideline was developed according to the Equator guidelines, and it is a standalone reporting guideline with 21 items that was produced by an international consensus. So this is the target checklist that was published both in JAMA and BMJ simultaneously recently. So it is the guidelines as to how to emulate this target trial. So guidelines on how to write the abstract, guidelines on how to do the introduction, guidelines on how to write the methods. Now here, and results, discussion and other information. So in methods they have two things. Like I said, the left column is your target trial or your hypothetical RCT that you would have designed. Could you have had the resources and the time? And target trial emulation, the right side is the observational data that you have now. How did you map it to fit into this RCT? So target trial, the target statement is now available for download on the Equator network as well. So we will look at a critical appraisal of a target trial. So my case scenario is a 61-year-old Mr. CAP presented with fever and productive cough spanning 2 days, and he required 2 liters per minute of supplemental oxygen on the day of admission. Suspecting a community acquired pneumonia, I drew a blood culture and started him on empiric piperacillin tazobactam and azithromycin. He defervesced and came off oxygen since day 2 of admission. So my question is, can I stop his antibiotics after a 3-day course? So there have been many guidelines that came up. The most pivotal is an RCT that was done in Lancet, which said that 3 or 4 days of antibiotics in a stable patient is non-inferior to a prolonged course, 5 days or more. Recently there was a target trial emulation that was published in Annals of Internal Medicine that I want to look at for this question, which looked at short versus longer antibiotic duration for community acquired pneumonias. So this is a multi-center target trial emulation. So we are going into the checklist now. Please stop me at any point if you don't understand anything. So the first part of the checklist is how do they write the abstract. So they have said identify that the study attempts to emulate a target trial using observational data. So they have to specifically mention that this is a target trial emulation in those words. They have said you should avoid terminology like emulated trial, emulated randomized clinical trial, which can confuse somebody that this is actually an RCT. You should make sure that the reader knows that this is actually observational data that has been mapped into an RCT format. So that they had done. They have said that explicitly stated that this is a observational emulation of a target trial, The objective was to evaluate safety and effectiveness of a 3 or 4 day course versus a 5 day or more course of antibiotic in hospitalized patients with community acquired pneumonia who achieved clinical stability by day 3. So this is just the PICOS statement in a pictorial format. So basically the setting was done, it was done in 67 hospitals across Michigan from 2017 to 2024. They looked at hospitalized adults with community acquired pneumonia in a non-ICU setup. So they have to have received at least 3 days of antibiotics and were clinically stable by antibiotic day 3. And they met the pneumonia short treatment trial criteria. This pneumonia short treatment trial is the one that I was talking about from Lancet. I will put up that criteria. So the intervention they looked at is either 3 or 4 days of antibiotics versus 5 or more days of antibiotics. And the main outcome that they were studying was a 30-day all-cause mortality. So this is the trial, the pneumonia short treatment trial. So the inclusion was 18 years of age, moderately severe community acquired pneumonia treated with oral or IV beta-lactam therapy according to European guidelines, and clinical improvement with all these stability criteria on day 3. They should be afebrile, not tachycardic, normal respiratory rate, almost normal saturation, normal BP, normal mental status. Any immunocompromised patient, healthcare associated pneumonia, complicated pneumonia, legionellosis, intracellular organisms, all these were excluded from the trial. So one critique I have at this point is the causal contrast they have said you have to mention whether you are doing ITT or per protocol was not mentioned in the abstract part. They have mentioned it later. Now the next thing is report the data sources used for emulation. So state that the analysis used observational data and that individuals were not randomly allocated to the treatment strategies of interest. So actually they have taken their data from this database called Hospital Medicine Safety Consortium, a statewide collaborative initiative sponsored by Blue Cross Blue Shield. But the thing is, they haven't mentioned this in the abstract. They have mentioned this in the methodology. That's why I have said that it has not been done. Again, in the abstract, they have said you have to summarize the key assumptions, statistical methods, and conclusions. So again, I felt they didn't do that. Only results, main result, and a few key limitations on patients in the short course antibiotic was given in the abstract. So that's why I have written no. They have specified it elsewhere in the paper, but the guideline is clear that this all has to be specified in the abstract itself. Now, next we are coming to the introduction part of it. So the first is the background, describe the scientific background and gap in knowledge. So this is what they have written. They have written that there is emerging evidence that short course antibiotic therapy for infections yields similar efficacy to longer durations while reducing adverse effects, lower antibiotic resistance. However, unlike our current study, trial did not assess mortality, had a limited sample size. This is, they are talking about the other RCTs that have been done, limiting generalizability to real world settings. So to better understand the effect of this in a real world setting, we emulated a target trial. So this is their rationale for choosing a target trial emulation. So I have given yes for that. Causal question. So the critique is that they have not summarized the causal question in the introduction part. They have summarized it in the methods part. And next part is, did they say the rationale? They said why they have done a target trial emulation specifically in this scenario. Then the next thing they have asked to mention is, was it done based on a completed or ongoing randomized trial? Was the hypothetical, the RCT that you described already based on a randomized control trial, or was it something that was made for this particular study? So actually these people actually emulated they made a hypothetical RCT, they didn't base it on any real RCT. But one thing is, in the introduction part, they did not say how the target trial was designed. It is written only in the supplementary appendix. Now we are coming to the methods part of it. So what are the data sources? Cite the data sources used for analysis, and for each one describe original purpose, type, geographic location, setting, time period. If relevant, describe how the data were linked or pooled. So they have done that. They have said that the data was collected from this Hospital Medicine Safety Consortium. It is an organization that collects patient level data on multiple things, including medical admissions, their course in hospital, antibiotics, including follow up after that as well. So of the 92 eligible hospitals in Michigan, 67 had participated in HMS during this study period, and they had trained abstractors collect the data for eligible patients hospitalized with community acquired pneumonias. So patients eligible for HMS were those who were admitted to general care, not ICU, between 23rd February and discharged between 23rd February 2017 and 31st July 2024, and received antibiotic therapy in hospital on day 1 or day 2. They had all this data, demographic data, vital sign, laboratory, concurrent conditions, antibiotic time and duration, outcomes. Also, they called patients 30 days after discharge to collect extra data about post-hospitalization outcomes, adverse effects, drug allergies, etc. So all this HMS database had already. Now, we are coming to the part about the specifications of the target trial. So like I said, on the left side is the hypothetical RCT, on the right side is your observational emulation. So this is from the supplementary appendix. I am going to be putting up this slide again and again because we are looking at each aspect of this target trial after this. So the first thing they asked was, did they describe eligibility criteria for this is all target trial specifications, okay. When we come to the emulation, I will write on top target trial emulation. So did they describe eligibility criteria, did they describe treatment strategies? So yes, they had described it in more detail also, but in this table they have given non-ICU adults with CAP, clinical radiographic diagnosis, stability by day 5, multiple exclusions, all this has already been said. So that is a yes. Did they report that eligible individuals would be randomly assigned to treatment strategies and aware of their treatment allocation? So they said yes, random assignment to either short course versus long course antibiotic after day 3 if stable. Then did they clarify that follow-up would start at the time of assignment? Okay, so in an RCT, time 0 is the time of assignment, is the time of your eligibility also. By time 0, you are eligible as well. So yes, they have specified that also. They have written here follow-up 30 days from randomization or assignment, outcome assignment with ascertainment with complete follow-up. So all that is a yes. Now next part. Describe the outcomes. So outcomes were primary all cause 30-day mortality. We are only going to look at primary outcome for our appraisal here. Causal contrasts, describe the causal contrasts of interest including effect measures, competing events if any. Relative risk, ITT versus per protocol was not mentioned, and no competing events. So what is not done I have written in green. So they have mentioned causal contrasts, compare risk of outcomes by relative risk for short term versus long term, but they have not written are they doing intention to treat or per protocol analysis here. Competing events means something that occurs before your event of interest can occur. For example, I am following up prostate cancer for 1 year to see mortality, but in between I have an MI and die. That is a competing event. They haven't mentioned about that also. Identifying assumptions is, so whatever you have to make a pre-specified protocol as to if you have missing data, you have losses to follow up, attrition, what are you going to do with all this. So that they had not done. What will they do if they are doing per protocol analysis, how will they adjust for losses of follow up. So I have given that a no. Then the next part is data analysis plan of a target trial. So here they have done a good job. They have said they want to do intention to treat. They have a pre-specified regression model, planned complete follow-up, and they have planned a sensitivity analysis also. All this is mentioned here in the data analysis part. With this we come to an end of what all had they specified about the target trial. Now we are going to the target trial emulation, which is the right side. So in target trial emulation, same questions we are going to ask again. But this is what they did in the real world. The first one was a hypothetical RCT. The second one is how are they using their data to fit into that framework. So actually how did they describe eligibility criteria? Same eligibility criteria that we specified earlier. Only patients who were alive or stable at day 3 were included. So actually here from time 0, there was the eligibility happened 3 days after time 0. That is something to note here. It was a small period of time only, but still if somebody died in that first 2 days, they would have not been included in the trial. But they have specified that, so I have given it a yes. Then treatment strategies, describe how treatment strategies were operationalized. So they have said either short course antibiotic is 3 days or 4 days of antibiotic, and long course antibiotic is equal to or more than 5 days of antibiotic. That is also mentioned. Then follow up, describe how assignment to treatment strategies was operationalized with the data. So they have written here that outcomes were tracked through 30 days, both EMR and follow up was done. Okay, sorry, I missed this bit about assignment procedures. So I'll just read this out to you and I'll explain this. So assignment procedures, retrospective group assignment using clone and censor, inverse probability censoring weights, and assignment once antibiotic duration is determined. Weights are calculated from logistic regression models predicting treatment receipt conditional on baseline covariates and time varying co-founders. I know this is a heavy thing to read, but if we go statement by statement, it is little more understandable. So I'll start with the last thing. So basically, when you calculate weights in logistic regression, they are saying we will do it both based on what you have at baseline. For example, 60-year-old man with diabetes will be sicker with a community acquired pneumonia than a 20-year-old man with diabetes, correct? So those are baseline confounders. Time dependent confounders are after I have come to hospital, if I develop some heat stroke and develop tachycardia, hypotension, that is a worsening, that will cause a worsen outcome of a pneumonia, right? If you have some intercurrent illness. So those are time varying confounders. Now I will come to this clone and censor concept. So cloning and censoring is a way in which you actually try to see in an RCT, when you have two arms, they are all baseline unknown and known confounders are adjusted, but that is not the same with the observational data, right? Your two arms might not be prognostically equal. So finally, if you get an outcome, you don't know if it is because of a difference in baseline or is it because of your outcome. Cloning and censoring is a way to somewhat equalize them at baseline. This is a cartoon I drew for cloning and censoring. So suppose I have a patient. Now, sorry, I didn't get your name. Amrita. Suppose Amrita is entering this trial, okay? I have Amrita's data with me at time 0, but I don't know how she is going to go on, okay? I am going to clone two Amritas, and I will put one Amrita in the short course arm and I will put one Amrita in the long course arm. Because it is two Amritas, all her baseline characteristics are equal, okay? So they are balanced at baseline. I put one Amrita in the short course arm, one Amrita in the long course arm. So the short course Amrita is going to take treatment only for 3 days or 4 days and stop antibiotic. The long course Amrita will take treatment for 5 days or more. Now I am going to follow up the real Amrita, okay? If Amrita takes antibiotics she takes 7 days of antibiotics, clone A is cancelled. Because the clone that did not follow, clone A was supposed to follow short-term treatment. Clone B was supposed to follow long-course treatment. If the actual patient has taken long-course treatment, I will censor the short-course clone. And I will only follow up long-course clone until day 30 to find out mortality. Similarly, if the actual patient has taken 3 days antibiotics and then they stop, which clone has been violated? The long-course clone has been violated. So I will censor the long course clone and I will only follow up the short course clone. So in truth, I have only 2 clones who have entered the study. One clone I stopped when they deviated from their protocol based on what the patient is actually doing in real life. And the other clone I continue to follow up. This is cloning and censoring. So at baseline, you have equalized whatever you could find out, known and unknown, you have equalized. But what have you not equalized? The clones might not drop out at the same rate. For example, the clones who are getting, if Amrita is actually sick only, she is going to get long course treatment, correct? So the clone A will be censored much more. Because long course people, most people who come to hospital to get admitted will actually be sick and might require more than 5 days of therapy. In our practical scenario also, very few patients who we admit to hospital actually stop antibiotic treatment in 3 days, right? So actually clone A will end up undergoing much more censoring than clone B. So at this point, it is not equal. So what will we do? We'll do weighting and analysis. So at cloning and censoring creates perfectly balanced groups at baseline. But censoring is not random and it could depend on how sick a patient is. So you do statistical weighting. which is called inverse probability of statistical weights. So you do this thing where clone A has less chance of continuing in the study, right? So you give, I'm just giving a very basic explanation. So you say that there is only 10% chance that clone A will continue in the study. There is a 90% chance that clone B will continue. So you make 9 more clone A's to account for the less chance that clone A has to continue in the study. This is a very rudimentary explanation of IPCW. But this is what happens. And this is done putting all their baseline and time varying confounders you're taking together and making this weight. All this software will do. You have to tell, if clone B, this age person is there with diabetes who has received antibiotic earlier, what is the chance that clone A will be censored, will continue? Very less. So you will make so many more copies of clone A to continue in the study. Okay. Now, one thing that begs the question here is, at what point do you censor them? So, if an actual patient is taking 7 days of antibiotics, you should censor which arm? You should censor the short arm, because the actual patient is taking long course antibiotics. When will you censor the short arm? Short arm actually can continue treatment only till 4 days. After 4 days, the short arm doesn't exist. So you should censor him on day 5. Did this concept, is it okay? Like when I'm taking a patient who has 7 days of antibiotics, what point do I censor the opposite clone? Opposite clone, the short course clone, can continue treatment only till maximum of 4 days. So at day 5, I will censor the cloning. But if an actual person takes 3 days of antibiotics, clone B can continue however long. But if I am choosing clone A, as in clone A is the one which I am choosing, I have to censor clone B. Then on the 4th day, I will censor clone B. And I will follow up clone A up to 30 days. So why is cloning and censoring important? It maintains exchangeability and ensures that at a baseline, the groups being compared are structurally identical. It eliminates immortal time bias, which means I am not analyzing data using future knowledge as to whether they are going to take short course or long course. Every person has equal chance of getting into short course or long course. There are 2 clones for every person. Okay. So this is the cloning picture that they have shown in this study. Okay. So just to understand this, see, patient A has clone A1 and 1A and 1B. Patient 2 has 2A, 2B. Patient 3 has, so this is short course, this is long course. Patient 3 has 3A, 3B. Patient 4 has 4A, 4B, and so on. So look at this. Patient, so this is censoring is this one, this symbol. Okay. So what do they do? Patient 1, this is day 3, this is day 4. Okay. Beyond day 4, clone A ideally should not exist. So what do they do? The first patient went on, took antibiotic till day 4 of therapy. So what did you do? It is a short course. So you have to censor the long course clone. So you have censored 1B. And you, at this point, clone A has finished their treatment and you're going to follow them up at 30 days for their outcome. Now let's look at the second patient. Second patient took antibiotics for 6 days. So actually you should keep the long treatment clone. So you censor the short course clone at day 5, because day 5 or equal, more than that short course clone cannot go on. Now for the sake of simplicity, I am not going to go into all of this, but they had some criteria for death. For example, I just want to say here that some clones, both clones are alive. See, like this clone, this patient 5, he took 4 days of antibiotics and died. I can't eliminate either clone because both clones are existing on day 4, correct? So I can't eliminate one or another clone because nobody has violated their protocol. I censor a clone only when the clone's protocol is violated. Neither protocol is violated. I took this patient 5 took antibiotics for 4 days and died. He could have been clone 1, he could have been clone 2. So sometimes there can be duplication of clones that occur. So for this one person, there are 2 clones that actually exist. Okay. Now I will go to We have finished eligibility, we have finished treatment strategies, assignment procedures, now follow-up. Clarify that the follow-up starts at the time that individuals were assigned to the treatment strategies. So follow-up started at assignment until 30 days post. So the reason they could do this is because they cloned everybody into both arms. So they could start follow-up and assignment. They were not waiting till day 3 or day 4 to see whether antibiotic is going to be stopped or not. So actually time 0 is equal to A here, is equal to the time of assignment. Describe how the outcomes were operationalized with the data. So they looked at the same outcomes. They didn't change anything from the target trial. They were looking, primary outcome was mortality at 30 days. Now causal contrasts. Describe how causal contrasts were operationalized with the data, including effect measures. So they did this weighted pool logistic regression for mortality. Then they did time to event analysis and they used stabilized weights and bootstrap confidence intervals. I had to just understand what these things were in English. So basically weighted pool logistic regression means you make that 30 days into day 1, day 2, day 3, day 4, and each clone is treated, every day for every clone is treated as a mini observation, and then you pool all these together. This is a simple English of what weighted pool logistic regression means. Bootstrap CI means, so like I told you, sometimes when we are cloning, you can have an artificially elevated sample size. So you have to do this bootstrap confidence interval, wherein if you have n original patients, each time the computer, so if this trial was supposed to have 5,000 patients and I made 10,000 clones or 20,000 clones, you can make how many ever, depending on how many ever interventions you have. Every time the computer will draw 5,000 patients from your sample and it will run this entire thing, cloning, censoring, IPCW, weighted pool regression. And then all these 1,000 relative risks, it will turn into a sampling distribution and give you the middle 95th percentile. It will exclude 2.5 and it will exclude after 97.5. And it will give you, that is a bootstrap confidence interval. This is when you have a bigger sample size than your actual treatment population. Next is to identify assumptions. So where are we? We are here. So again, IPCW and cloning adjust for baseline and time varying confounding. So yes, they had identified assumptions related to the causal estimate. And describe how the variables related to these assumptions were operationalized with these data. So they have described how they handled missing data and special cases as well. So they had 132 patients with missing complete data on follow-up. What they did was they went back and contacted all these patients. And then they actually looked at, so they found that on day 3 and day 4, somebody had allergy and the antibiotic was stopped. But after that, the doctor didn't require further antibiotic. He didn't start an alternative antibiotic. So that means 3 or 4 days antibiotic was enough for this patient. So they went back, looked at all this data, and they came to a conclusion as to whether it was short course or long course. And finally, only 22 patients, so 0.4%, because they lacked baseline demographic data, they excluded. Finally, we are coming to the data analysis plan. So the data analysis plan, for each causal estimate, describe the data analysis procedure, same thing that we discussed. So they have described all this and they have said how they will handle missing data. Then for each causal estimate, describe additional analysis that were used to assess the sensitivity of the results. So they did this special characterization of those who didn't complete antibiotic duration. 22 they excluded. They did sensitivity analysis versus with this bootstrap confidence interval. So yes to both. So at this point we have finished abstract, we have finished introduction, we have finished target trial specification, we have finished the emulation. Now we are coming to results. So report numbers of individuals assessed for eligibility, eligible, assigned to each treatment strategy. Flow diagram, they have drawn this. So let's look at the flow diagram. Sorry, the top part got cut off. Okay, they got, 55,517 patients with community acquired pneumonia that were hospitalized. Then 49,000, 89% of these people never met eligibility criteria. So the idea of this being like pragmatic is a little in doubt. Anyway, they have given the reasons for exclusion because they followed the original RCT's exclusion criteria. It was a very rigid exclusion criteria. So this is something that has to be provided as part of the diagram, and they have done it. Then finally, they included 5620 patients. If you have 5620 patients, for 2 treatment arms, there are 5620 clone A and 5620 clone B. So they had so many clones. Then, out of this, the dyed is included in the uncensored clones. Only somebody who, I mean, death is not a censorship criteria, okay. So, 454 were uncensored at the end of this, of which 3 had died. Again, 5176 were uncensored at the end of this arm, the long course arm, of which 37 died. So, the censored clones were 91% in the short course arm. So, this again comes back to our understanding that when lots of people continue one arm, lots of the opposite clone will be censored. So, look here, 91% were censored in this arm and only 7.9 were censored in this arm, which means there is a huge number of people who are taking. So, this is what will happen. Whatever you try to emulate in RCT, you can never emulate to the full extent of an RCT. There will always be some baseline difference. So, baseline data, they have done a baseline. They have not classified it as per the treatment strategy, but anyway cloning was done. So, you need not really classify. Missing data for 22 patients were excluded. So, this is the baseline. They have a very extensive baseline. I just highlighted some things that might be important to our scenario. So, some 0.6 were Asian, 3.6% of the people of this 5620. 3.6% were in skilled nursing facility. They had a good mix of comorbidities, congestive heart failure, COPD, cancer, diabetes, cardiovascular disease, a lot of the things that we also see in our medical wards. And then current smokers were also included. The median curb score was 2. They had received some high risk antibiotics in the past 3 days, which means there were people who were coming back to hospital recurrently. There were people who were hypoxemic that were included. Median PSI score was actually quite a few people from the class 3 and class 4, which are actually very sick people. And they had included people with exacerbation of COPD as well. Now, the antibiotics that we give, the guidelines there are basically ceftriaxone, and it's a beta-lactam with a plain beta-lactam without a BLI, without a beta-lactamase inhibitor, and azithromycin. So, the peptides that we use is only 1.6%. Most of them were actually on ceftriaxone and azithromycin. So, we are coming to the results. Before that, follow-up. So, the follow-up is for each eligible person, follow-up started at assignment of treatment strategy, day 1, day 3 and ended 30 days later. 91% in the short duration group was censored, and 7.9% of the clones in the longer course were censored, and 20 clones were remaining uncensored in each group. So, actually these 20 clones, I feel they should have made this as 5630. 20 clones means 10 patients. They should have made this 5630. I don't know why they didn't write that. But the truth is, it doesn't change here because you will minus 10 from both arms anyway. So, the total number will not change. Missing data for 22 patients again were excluded. However, it is not given as to which treatment strategy they belong to. Describe the frequency or distribution of the outcome by treatment strategy. So, relative risks for 30-day mortality was presented. So, this is the results table. We are looking only at 30-day mortality. So, risk difference is basically they have done the relative risk for people in the short course arm versus the long course arm. Now, see here their N is actually 5630 because they had 20 clones who were not censored in either group, but they have not written that in their main diagram. Anyway, when I redid this analysis, I had a small difference in the total outcome. So, finally we are looking at those who died divided by those who are uncensored. So, population who had the outcome versus the total population, and in the other arm it is 37 versus 5176. Sorry. So when I did that calculation, this one came to 0.66 for me and this one came to 0.71. So the adjusted risk ratio after adjusting for, they have adjusted for weighted pool regression logistic models for baseline variables and time varying variables. So finally it was 0.89. Now when we are estimating a relative risk, we can see that this crosses 1, so it crosses the line of no significance. So it might not be significant. This is the survival curve. Here there was some difference in the clones that were remaining in each group again. There is no explanation for this as in the supplementary also, because we had said that finally 5166 clones should be there, but here it is 5139. And here also we have said that there should be 444 clones, but there are 447 clones. So there was some variation with what they have shown in their flow chart.
Is there an overlap of the confidence intervals, short and long? The picture, same picture.
Yes, sir. Yes, sir.
Just repeat it.
There, the question was, is there an overlap of the confidence intervals between the short and long? So yes, the confidence intervals for the long duration are within the confidence intervals for the short duration therapy. So again, this makes your effects estimate dubious. So effect estimates, they have reported 95% confidence interval, but p-values were not reported. So I have given that a no. And additional analysis, they have done sensitivity analysis which showed that basically they did it for people who have received antibiotics for 3 days in a hospice before coming to hospital. So they have said that even among those people who got some extra antibiotics, there is no very big difference between short course and long course in terms of 30-day mortality. So this is the same thing, 7.2 and 7.5, 75%, 72% and 75%, and finally the adjusted risk ratio comes to 0.96, and again it crosses 1, which is the line of no significance. So what is the interpretation? They have written down this interpretation clearly, so I have given this a yes. They have said we have emulated a target trial of 5620 patients who are admitted to 67 hospitals and looked at assignment on day 3 for short course versus long course antibiotics. So they have mentioned that only 10% of our initial general population was eligible in the first place. Out of that, only 8% got short course antibiotics. So it was a very small number of people who actually were in the short course antibiotic arm. All outcomes including mortality, readmission, urgent visit, C. difficile infection, adverse events were infrequent and similar between both the groups. However, given the impression of the estimates, our results are compatible with both benefit and harm, which means the relative risk is crossing 1. So you can't say on either side whether which arm is better. Discuss the limitations of the study. They have done that. They have said that the causal inferences relied on the assumption that there was no selection bias. So this might not be true. Suppose doctor says, I will stop antibiotics because patient cannot buy antibiotics anymore. That is a selection bias. But they have not accounted for factors like that. They have relied on the assumption that the doctor's decision for antibiotics is purely based on clinical stability of the patient. There is a small sample of patient with short duration antibiotic therapy and low mortality rate. So basically there was a very small number of people who were in the short course arm finally. They excluded some 90% of the people, and out of the remaining 10%, only 8% were in the short course arm. Study's 30-day follow-up period precludes assessment of longer term outcomes, and clinical stability criteria might not fully identify higher risk eligibility elderly patients because they were all excluded as ineligible. So this is the last bit of the checklist. Ethics, they have said University of Michigan Medical School IRB has done. They have not given IRB number. They have not. They have written that informed consent need not be taken because it is a database-based, registry-based study. So, like when you sign up in the hospital itself, they have signed up that my data can be in a registry. So they don't need to take informed consent separately. Registration is not done. They have not mentioned at least where the study protocol was registered. Provide information on whether data analytic code are accessible. They have not said that. Source of funding is this Blue Cross Blue Shield Michigan Blue Care Network, and they have written specifically that funding source had no role in the design, conduct, analysis or reporting of the study, so that's a yes. Conflicts of interest have not been mentioned. So would I use the results of this study? I would still say yes, because it is an important question. It is, I think, valid for a target trial emulation. It was a well written abstract and methodology, and they have taken some lot of effort to clone and censor and weight all the, both the arms. And the outcome that they chose was an important outcome. It was 30-day all-cause mortality, and they had a good discussion, and they had mentioned the limitations of the study. So within the framework of it being an observational study, it was useful data. So case scenario, coming back to my case scenario, would I stop his antibiotics based on this? If he is clinically stable on day 2, then yes, I would probably stop. These are my references. If anyone has any questions, we will take.